Krishnaswamy. He's a section head of Interventional Cardiology at Cleveland Clinic. And he's a very good friend of mine and very expert in the structural heart disease. He's also in charge of the cardiovascular and interventional cardiology at the Cleveland Clinic, program director. So let's start with the Amar. May I invite Amar to come first?
Sure. Let me share the screen so you can see my slides.
Yeah. Yes, of course.
Okay. You should be able to see all of them now.
Yeah, absolutely. No
Good.
problem.
Thank you, Dr. Bang. Thanks, of course, to all of the audience who's listening in, and to my co-speakers. This looks like a fun agenda. It's my pleasure to speak with you about, first, to start with the idea of percutaneous mitral paravalvular leak closure. What are the concepts there? And then how can we apply this to a sort of a nightmare situation during MitraClip therapy? I have no relevant financial disclosures. So as I said, I'd like to outline these technical aspects of mitral PVL, and then we'll go over a case of a single leaflet detachment during a MitraClip that we treated using these same concepts. So this is a 49-year-old gentleman. He underwent mitral valve replacement about 1 month prior. And you can see here in the 3D echo, he has a large paravalvular regurgitation posteromedially and another origin posterolaterally. Now, in the right fluoroscopic panel is a different patient. Of course, that patient has an AVR and an MVR, but just so that you kind of in your mind gather the fluoroscopic landmarks, in the LAO projection, the posteromedial aspect of the mitral valve is here, the posterolateral aspect of the mitral valve is there. So just to translate the echo anatomy to the fluoroscopic anatomy. Generally, our procedural approach in these mitral PVLs is we do these procedures, of course, via femoral venous access with a routine pre-closure using the per-closed proglides. Our practice pattern in Cleveland Clinic is to do these procedures under conscious sedation. So we perform the transeptal puncture using intracardiac echo and fluoroscopy. Because we have planned the procedure based on the pre-procedural echoes, we were able to direct ourselves fluoroscopically to the location of the leak. And then once we've introduced a couple of plugs, we'll have our imaging colleagues place the TEE to understand if we need to implant more devices or if we're done with our procedure. They, of course, are accomplished in doing this under conscious sedation, so we're able to avoid anesthesia team and intubation and so forth. The transeptal puncture is, of course, a very important part of this procedure. Again, this is the ICE images from a different patient, but you can see here in the top left here, we want a posterior puncture and we want an inferior puncture. And the idea here that you can really appreciate fluoroscopically is that by puncturing in the back and the bottom of the septum, we have all of the atrium to be able to access the mitral valve and really advance these bulky catheters and devices. The equipment we start with, usually we use a steerable guide catheter. We tend to use the Agilis or the Nagare from Terumo. But in any case, a steerable guide catheter through which we place a long angle glide catheter in order to have a little bit more articulation at the tip and directionality to move around the mitral annulus. And then, as you can see here, this is our current patient. You can see the dots of the mitral flow ring. You can see that we cross the leak with the glide wire and then pass through with the glide catheter in order to ultimately provide more support. And you can see here in this patient, we've first decided to tackle the posteromedial leak, as you can appreciate in the LAO projection. Once we cross the leak, we usually oftentimes advance the glide wire out to the descending aorta, and then using a typical 915 end snare, grab the wire in the descending aorta and externalize it to the femoral artery. And this provides a nice rail from the femoral vein across the septum through the leak and then back out the femoral artery, again to provide some support to deliver these bulky devices. In someone with a lateral mitral annulus leak, generally you don't need this kind of support. So sometimes we'll just advance a stiff wire to the aorta, or even just leave a curled wire in the ventricle. But especially in patients with a posterior leak, with a medial leak, where it's a lot of acute angles coming from the septum, having this kind of an externalized wire support is really beneficial. We then like to deliver most commonly the AVP2 device. Of course, outside of US operators often like to use the AVP3. That's not something that we have available currently in the United States. So we tend to default to the AVP2 device, and we usually deliver this via the 180-degree TorqVue. Now, while this device in most of its sizes will advance through a 6 French delivery, we prefer to use the 8 French, and I'm going to show you why in a moment. So you can see here, this is the TorqVue delivery sheath sitting just at the area of the leak. And we've advanced the sag wire through the leak. We advanced the TorqVue over the sag wire to the leak. And then because we've used an 8 French, we're able to deliver our device with the sag wire still in place. And the reason that this is beneficial is that now that we have one plug advanced, especially in these leaks that tend to be large and you need more than one device, we've still reserved the place with our sag wire across the leak. So all you have to do is pull this TorqVue delivery out and then just replace it over the same sag wire, which is already across the leak. And in that way, you can implant as many devices as you want by just repeating these steps. And so you see here, we have the TorqVue across the leak. We have the first plug that we had implanted, and then now we can just advance our second plug. You can see there we have 2 plugs in place, and we still have the wire across the leak in case we need more devices. And you can appreciate in this TEE, sorry, I'll play that again. You can see in the TEE that posterior medial leak, which is right here, you can still see leaking around the plugs. So clearly we need more devices. And again, this is the point at which our imaging colleagues placed the echo probe. So you can see now, again, we just simply repeat the same steps over and over again. And we have 3 devices placed. Now we have 4 devices placed. And now that posterior medial leak has really closed off. You can appreciate there in the fluoroscopic image that posterior medial leak that we had intended to close first. So we went ahead then to attack the posterior lateral leak. You can see here in the biplane fluoroscopy, again using the same system, the Agilis, the glide catheter, and the glide wire crossing posterolaterally. And if you have difficulty crossing, the live 3D echo can really be quite helpful. You can see this echo image from our imaging colleagues. We know that the leak is here posterolaterally, and in this position, our catheter is too much in the orifice of the mitral valve. You just clockwise the catheter to go posteriorly, and you can see here aimed right at the leak. Once we cross the leak, it's the same steps again. We implanted one AVP2 device. We realized there was a little bit too much leak. Using the same system, we can implant a second. And so in final answer, we have 2 plugs here in the posterolateral portion, 4 plugs in the posteromedial portion, and really, I think, a very nice result in the end, trivial residual mitral regurgitation. And within 3 days, gentleman was walking around his neighborhood without any difficulties. So how can we sort of extrapolate these concepts to something that we encounter, hopefully not too often, but certainly do encounter with MitraClip? This is a patient, 84 years old, with a prior bypass surgery, now with exertional dyspnea. And you can see here the typical FMR, some apically tethered mitral leaflet, some annular dilation, restriction of the posterior leaflet, and the mitral regurgitation that you can see there directed posteriorly. So of course, we decided to bring him for a MitraClip. You can see here in the leftmost panel, the clip is aligned at the A2-P2 segment, which is really around where he had his mitral regurgitation origin. You can see here the middle panel, just the clip is open. And we put the clip, as you see there in the middle of the valve, we closed it, and you can see here trivial residual regurgitation. We were very happy. Our imaging colleagues were helping us to analyze that the clip was appropriately attached, which it seemed to be. And unfortunately, all of a sudden, while the clip was still attached to the delivery system, you can notice here that the posterior leaflet has become unattached. And you can see here a very messy jet of mitral regurgitation. And importantly, after a lot of analysis, what we determined, in fact, was that it wasn't that the posterior leaflet had just slipped out because we had such a good grasp of the posterior leaflet. It was, in fact, that the leaflet had torn. And you can really appreciate that when we let go of the leaflet altogether. You can see the mitral regurgitation jet both in the origin of the orifice, but also here where the leaflet has essentially become perforated, carrying the leaflet between the annulus and the leaflet tip. And so this is a situation which it's certainly not common, but in some series you can see almost anywhere between 3 and 5% of the time a single leaflet detachment, either due to tear of the leaflet or in fact due to slipping off of the mitral clip itself. When the mitral clip slips off, of course, it's a little bit easier to handle because you can just hopefully recapture the leaflets, but this is a more complex scenario. So what we decided to do here was we thought we would create a frame by which we can essentially place a vascular plug, a paravalvular leak plug. So what we did was we moved the mitral clip a little bit medially. In this fluoroscopic panel, that black triangle is where the clip was originally. We moved it a little bit more medially, as you see here. So as expected, you can see that there is regurgitation just lateral to where we have our clip. You can see that again in this 3D echo. You can actually see that hole in the posterior mitral valve leaflet, creating that new orifice there, just lateral to where we decided to place the first clip. We then took a second clip. The arrow there is where the first clip sits. As you see, we placed the second clip now just medial to that tear in the mitral leaflet. And you can see there, as expected, we have a leak now in between where we put the two clips. Fluoroscopically, you see these two clips here, one a little bit medial, one a little bit lateral of the original position. And when you look to the ventricular view of the 3D color echo, you see very focally that leak that sits now in between the two clips we have that we had really implanted to provide a scaffold. So from there, we just used sort of our PVL closure concepts. We took an Agilis, as you see there, a glide catheter and a glide wire that we have used to cross into that new orifice that we created. You can see the system there, the glide catheter and the glide wire. Once we advance the wire out to the descending aorta, we are advancing the TorqVue catheter, as you see here. Because this is a reasonably large orifice, the angles are quite favorable. This is not a situation where we would routinely snare the wire in the femoral artery. And you can see here now the TorqVue catheter is advanced into the leak, and we've implanted a 14 millimeter AVP2 device. In fact, you see it beating with the mitral valve opening and closing quite nicely. It's a nice 3D echo image here that shows you again the creation of that scaffold by the mitral clips to place this AVP device. You can see here the motion on the echo that you could appreciate on the fluoroscopy as well. And the final result actually is a very nice one. It's sort of a trivial leak that's occurring through the AVP device itself, which we see, and over time, as this device thromboses and endothelializes, this leak that happens through a device should really go away. And ultimately, the patient did very well. In fact, he was a very sweet old man. He needed to use a cane when he was having such bad exertional dyspnea. And he felt so well after this, he even got back to riding his exercise bicycle. He actually mailed me his cane. And he said, I know you don't need to use a cane at your age, but it means so much to me how well I feel. I want you to keep my cane. And so it sits in the corner of my office still to this day. So to conclude, PVL after surgical valve replacement really can be effectively fixed using percutaneous therapies. I think the data for this has been quite supportive. The Emory group has written a nice paper on this as well. And so I think in large part, as long as anatomically feasible, personally, I feel the percutaneous strategy should be the first step in treating these patients, not reoperation. Devices and techniques are, of course, not specific to PVL closure, but have been modified for use from other percutaneous procedures. And while single leaflet detachment with mitral clip is uncommon, it can happen about 3 to 5% of the time. And so operators really must be prepared for this complication. The treatment, I think, depending on the etiology, can be percutaneous or surgical. And in truth, many times when you see a leaflet tear like this, I think the default in our minds is that, oh no, this patient has to have a surgical repair. I think if you understand the spectrum of structural cardiac interventions, I think that's how you can really provide some unique situations in some of these nightmare conditions, and hopefully still provide the patient a good result with a percutaneous treatment. So thank you really very much to all of you for your time and your attention, to Dr. Bang for organizing. I really appreciate the opportunity.
Thank you, Amar. It's excellent presentation. You have virtually covered all the aspects of the paravalvular leak, both in mitral valve position and nitric valve position. And basically, you saved the lives of those 3 patients. We will have question answers at the end, where after all the talks are over. Now I would like to invite the next speaker. And next speaker is Dr. Farouc Jaffer. He is an associate professor of medicine at Harvard Medical School and director of coronary intervention and chronic total occlusion PCI program. And may I now invite him to deliver his talk. Farouc?
Okay, great. Sorry, I was on mute. Thank you. Good morning and good evening in India. Thank you, Dr. Bang. It's a pleasure to be part of this really exciting session to talk about high risk and unusual situations and how to deal with kind of rare events, but important to be able to have some of these tools at our disposal. I'm delighted to be part of this great panel and group, so thank you. I'm happy to present some interesting cases regarding left main and CTO PCI and some complications and understanding how to manage them and salvage certain situations. These are my disclosures. And I'm going to use the great. And we'll start with the first case, and this is an LAD total occlusion. And can I just confirm everyone can hear me?
Yes,
it's okay? Okay, super.
No.
Great. So this is a 74-year-old gentleman who had a single vessel severe CAD with a left anterior descending CTO with a JCTO score of 1 for calcium. It was a 7mm lesion, so not particularly long. The distal cap was at the location of a very important bifurcation, D1. He had a high-risk stress test and large area of anterior ischemia, and therefore felt to be appropriate for revascularization. High BMI, not an optimal surgical candidate. After a discussion with the surgeon and the patient and the referring cardiologist, the decision for CTO PCI was moved forward. Because of his larger size, this case was done biradially and with a venous sheath in the right IJ. We used the 7 French system for the antegrade side, and were able to cross quite smoothly with our third wire, Pilot 200. After crossing into the diagonal, our goal was to try to rewire the LAD, and this we did with after low pressure dilatation, and then use of a dual lumen catheter allowed wiring of the distal LAD. And did our usual thing, which was to do angioplasty and then imaging, typically by IVUS or OCT, to understand the degree of plaque burden, normal reference segments, and so forth, and degree of calcification. So at this point, we felt we could go on with kind of routine stenting using a trap wire in D1. This was a long stent placed. The osteal D1 became tighter, even despite the pot technique. We decided to rewire this and plan for a kissing balloon approach. So this was performed, and you can see here we have good support from the guideliner. It's very close to the LAD stent entrance, something to keep an eye on. As we began to try to traverse D1, which had been rewired, and with the target of rewiring past the distal into the distal strut, we were not able to cross. At that point, we did not have 1.0 balloons that we do now, but when this case was done, we had 2.0 and 1.5, so we brought in an extension catheter. 1.5 balloon still would not cross. We then used a glider balloon, which is this balloon that has a skeeve on it that sometimes can swivel through. That would not cross. Then multiple microcatheters would not cross. And the D1 flow, as you can see here on the right side, is starting to worsen. So the question is what to do next? So our thought was that maybe we crossed in a difficult part of the stent strut cell, and we were going to try to rewire with a different wiring system. This was successful. We recrossed with a second wire. However, one thing that we noticed is that the initial wire, which was in the diagonal, was very rigidly stuck in there. It would not come back. Every time we pulled back, the guide extension was starting to come in, and soon you're starting to notice, boy, there's this very dense radiopacity right here where the stent entrance was. So this is something that is very concerning for stents being deformed. We ultimately had to pull back both wires. It's in order to get the first wire out, and we were able to do that. And the flow down the diagonal now has markedly reduced. And while this is a total occlusion and there's some collateralization because of his higher risk stress test, we certainly were aiming for complete revascularization and interested in trying to keep that diagonal open. So we thought, all right, well, let's go back and try to re-expand the stent and recross. So the LAD stent is there, but now, even though we have an LAD wire down, we cannot cross this initial stent deformation area. Okay, you can see this dense radiopacity. So we tried multiple microcatheters. Ultimately, we chose our narrowest profile one that we had access to, a Caravel 135. And that was able to cross about halfway into the stent, okay, right before D1. And we were able to do some angioplasty of the proximal zone, but really not get the balloon all the way into this kind of morass. And we can't deliver anything further. So now we're faced with a dilemma. Obviously this person is still a surgical candidate, but it's suboptimal. So we thought that one way to potentially deal with this is to see if we can do something to change the stent architecture to allow us to be able to deliver equipment and re-stent. And so ultimately what we did is we were able to bring our Caravel catheter into the mid-LAD. We gave up the distal wire access and then bare wired from that point with a rotational atherectomy stiff wire into the LAD. With the plan that we were basically going to burr through the deformation of the proximal stent. This was successful using sequential 1.5 and 1.75 millimeter burrs. We were glad we were 7 French in this situation. We were able to then do angioplasty. We re-IVISed and we clearly showed this deformation, both compression and stretching across the stent. This is ultimately re-stented with a 2538 and NC 3.0 balloon. While we had TIMI 1 flow to TIMI 2 flow here, it was still open, and we were definitely not interested in rewiring that one more time. We were going to leave him and let symptoms dictate whether or not he was actually going to need further therapy. So that was a one case where really recognizing this concept of longitudinal stent deformation might be in place. So let's just talk a little bit about that for a second. It can happen with really any stent. The risk factors are proximal lesions. And so use of a guide extender near a proximal stent is a risk for interaction. Crossing with higher profile devices when things are on an angle, one can also have a stent hitting another stent. That's another very common cause of stent interactions. Thin strut stents may be at higher risk, but really it can happen with any stent. And as you can see here in these panels, that we can really, deform almost anything. It's reasonable if one does recross to re-angioplasty and stent across it to overcome that deformation zone. All right, so we'll move on to our next case, and this is a case of a couple cases of perforation. And this is important for those who are interested in CTO PCI. Perforations are really the #1 risk that is more unusual, more prevalent than standard coronary intervention. And in our open CTO registry of 1,000 cases in the US by Grantham and colleagues, by core adjudication, there was a 9% incidence of perforation. And about half of those are clinically significant. It's important to resolve ambiguity and try to prevent this. It's better to resolve ambiguity early, look at the films carefully, look at CT, use IVUS. Do not advance a microcatheter over a wire if the wire is not clearly identified to be in the main architecture. Try to avoid stiff wires whenever possible and convert to retrograde early in these situations rather than pushing forward with stiffer and stiffer wires. Avoiding high-risk collaterals on the retrograde side are super important as well. Epicardials are more fragile, and those take more time to actually become skilled at and have real expertise in complication management. And if there is a lot of calcification, limiting rather than going with very high-pressure balloons and very large balloons is to consider atherectomy even when subintimal. It's important to be able to prepare send type and screens, make sure that you've really looked at long runs and understand your anatomy. As far as reversible anticoagulants, we do our cases on heparin, avoid bivalirudin. We do not fully reverse, but if we're at 400, we might reverse down to 220. Pericardiocentesis trays in the room, covered stents, coils are really important, especially those distally that can go through 014 microcatheters, and those are typically neuro coils, so please collaborate with your neuro or interventional radiology departments about having those available if you have very distal perforations. Then there are other ways to include things besides coils, thrombin beads, fat, gel foam. Those are all protocols that are worthwhile having in the lab for CTO programs. And then ultimately understanding whether or not patients do have CABG backup and mechanical circulatory support. So coverage stents are important. They come in many sizes. These are devices that are essential and are available in really every Cath Lab. They are important, again, to look at the range of what they can do, and I'll show you a little bit more about specs in just a moment. So here is a case of an RCA perforation. It was a post-CABG right coronary total occlusion, and this was a turn down for redo CABG because he had prior radiation and lung cancer. The JCTO score was 1 really for calcium. The mid-RCA was tapered and diffuse. It was not a particularly complicated one here in this zone to wire, about 15 millimeters. So this actually did successfully wire. And you can see here microcatheter is coming down the wire is basically going to end up in the distal RCA. So this allows us to do typical balloon stenting, but after the end, we're ready to celebrate. And after putting 2 DES in, we recanalize, but then we're starting to notice, and this is why we do really long runs. At the end here, so we're starting to see there's something that's not quite right. And what we're seeing are 2 jets of extravasation out of the main vessel. And this would be potentially an Ellis grade 2 type of situation. And our next step then, of course, is to immediately balloon occlude. And after occluding for 2 minutes, we took care of actually one of them. It got better, but the second one was still leaking quite significantly here. And while this is something that one may be tempted to, in a proximal vessel like this, large vessel, this is a really good situation to put a covered stent in. And Graftmaster bare metal 3519 was placed in different angles below this RV marginal branch, ultimately with effective sealing. There's a small effusion at the end of the case, no tamponade and no chamber compression. One thing about post-CABG perforations is that there may not always be a pericardial effusion, but there can be atrial hematoma that effectively causes the same form of tamponade physiology. So it's critically important to recognize that and prevent it and be definitive with treatment. This is just for reference. Here's a nice review from Colombo and colleagues looking at a management for stepwise management for looking at perforations. understanding whenever possible to immediately go up with a balloon, look at hemodynamic evaluation, understand cardiac surgery, and really then thinking about, well, where is the vessel, where is the actual perforation occurring? Is the distal main vessel, the distal side branch, proximal side branch, or the proximal main vessel? And particularly if there's a presence of a bifurcation, to think about in this recommendation surgery, if there's not a bifurcation like in our last case, to go straight to covered stents in these larger vessels. And this is a nice overview I encourage people to look at. Just looking at the Graftmaster itself, there are two sizes, and we'll talk about the newest development in covered stents as well. Important to recognize that they're relatively high profile. For the larger stents, one needs a 7 French guide. It's hard to deliver these through guide extenders unless you're looking at 8 French guide extenders. It's important to choose the length to avoid jailing major side branches, which will then be cinched off, and the stents can foreshorten 20 to 25%. It's important to dilate at high pressure, 16 atmospheres, and then further post-dilate. And one of the important features is to realize that they can all be actually expanded to 5.5 millimeters. So if you only have a 2.8 on the shelf in a large perforation, it's still an option to deploy that and then dilate it. Papyrus is a newer stent. This was released from Biotronic in the US about a year ago now, and this has really changed our ability to deliver thinner strutted stents. There's a lower crossing profile, only one coverage of plastic PTFE. These are now more 6 French compatible here for even the larger sizes up to 5.0, and the stent graft expansion can also get they're more constrained, so it's important to recognize that, but the 3.5s and the 4.5s can get fairly large. All right, so ultimately we were able to place this covered stent below that RV marginal and post-dilate it. We still have this crescent here, but there's no longer frank extravasation. Ultimately, a patient was fine, did well, no tamponade. Here's a second case that I thought would be also instructive. This was a case of left main intervention and a difficult situation. So this gentleman was 83 years old. He had a circumflex PCI in the past. He had asthma on chronic steroids, prednisone 10 milligrams per day, anticoagulated, sleep apnea, hypertension, hyperlipidemia, hypothyroidism, and a high BMI at 37. He presented with chest pain and dyspnea, was found to have a non-STEMI with an ejection fraction of approximately 45%. Catheterization, and we'll show these pictures, had a distal 50% left main, severe proximal calcific LAD, and a really severe osteal circumflex lesion. Normal creatinine. He had a cardiac surgical consult, referred for surgery initially. His syntax score was high. His syntax 2 score was also high. But unfortunately, his surgical score for STS mortality was very high. And we had a heart team meeting, and I encourage you to look at this reference. We recently published in the Journal of American Heart Association a structured heart team form, which can be useful for decision making, and detailed 150 cases and their outcomes. The overall decision, having a series of cardiac surgeons and interventionalists review the case, was to proceed with PCI. Here are the initial pictures, and this procedure was performed by Dr. Stefanescu, who helped me with this presentation, an MGH cardiology fellow. In this segment here, there is a moderately severe to 50% distal left main compared to the osteal reference segment here, which is quite large. This area gets to 70, 75 diffusely calcified in the LAD, and then the ostium of the circumflex is 90%. So this is effectively a 101 Medina classification, but because of the need for diffuse stenting across the LAD, this was felt to be approached with a standard a DK stent for the left main. This worked with initially a staged procedure, and so because of his high BMI, we were particularly interested in going radial. He had an IJ sheath, and he had a 7 French guide, allowing us to basically take selective pictures. We did a right heart cath first and showed a high wedge of 23. We confirmed that this was physiologically significant into the left main, into the LAD, and the IFR was quite severe at 0.67. We then angioplasted into the proximal LAD that was greater than 270 degrees of calcification, and therefore he underwent orbital atherectomy then LAD, DES stenting into the proximal LAD, and then we addressed the left main with a circumflex DES in DK fashion, followed by a final left main to LAD second stent. And after rewiring and doing kissing balloon angioplasty, we had a concerning result here. So this is first after the DK results. So here's the angioplasty, and now we have this result here. So this is perhaps like one of the most dramatic complications, and this is one where clearly this is an emergency situation here and a life-threatening issue. So he developed severe chest discomfort, and this is due to a double perforation here, one at the bifurcation of the left main, one here at the distal left main. You can see here what we would call Ellis grade 2 to potentially 3 class here with greater than 1 millimeter. Not cavity spilling, but still clearly going into the adventitia and surrounding structures and potentially into the pericardium. So of course we want to typically balloon occlude when we have perforations, but remember now this is the left main. So we don't have that option for very long. So what are the options? Well, we could think about emergency cardiac surgery and then trying to ligate or plug the coronaries after grafting on pump, but he was already effectively declined with a high STS score. What about a covered stent? This is proximal, but the one trick here, challenge is that this is going to involve the ostium of the circumflex. So we might end up losing that if we do it. And do we have options for mechanical support? And a gentleman has a very high BMI. This can also be tricky to put in impella 14 French sheaths. So ultimately, we recognized that we thought we might have a landing zone at the distal left main bifurcation to be able to place a covered stent, and then we did a Papyrus 5.0 here, trying to get this delivered and try to nail the distal ostium, and we did. And initially we had flow, but when we post-dilated, we ended up sealing off the circumflex. And while he actually improved initially, as soon as that circumflex went down, he again became unstable, chest pain, hypotension. He ended up being intubated emergently on pressors. And so now what are our options? And this is where we had to really, decide if we were going to kind of push the limits here. Again, emergency surgery really not an option. You can see here the initial DK stent is really outlining the circumflex. We were able to place a balloon pump with my colleague, Dr. Rahul Sakuja, did that on the left axis. And then we said, our only option here is to see if we can actually puncture the plastic of this covered stent. And so to do that, we took a angled microcatheter. This is a supercross catheter from Teleflex. We took a 90-degree version, and we took the stiffest wire we had, which was an Estado 20 gram. And you can see here that we're trying to get a lip where we can actually puncture. It's going into the subintimal space and maybe exiting. Obviously, that's a concerning situation, but ultimately, it is able to track the main circumflex. The supercross itself followed. Then we did angioplasty, ultimately re-imaged and actually then re-stented with the DES in a final kiss here with a kind of standard DK approach, allowed us to ultimately succeed in this area. So fortunately, he did well. He was discharged 8 days later and after a leadless pacer with a normal EF. For those who are interested in complex PCI, Sky has recently put out a position paper about some of the aspects of complex PCI. I do encourage you to read this. This was just published in CCI a few days ago and is open, available. So in conclusion, I'd like to just comment that stent deformation and perforations are not uncommon. Preparation and focus and prevention are key. Understanding the toolbox for managing perforations from covered stents to coils and embolization materials are critical. Avoid full reversal of anticoagulation while treating. For target vessel perforations, understand if key side branches will be compromised because one might need to do unusual things like in the last case. And then ultimately important to stay calm, call in your colleagues. I want to thank the MGH Cath Lab fellows and the attending staff and nurses and techs who make all of this work really possible. Thanks very much. Looking forward to your questions at the end.
Yeah, brilliant presentation. Absolutely brilliant presentation. Very good cases. All 3 cases, brilliant cases, and there are a variety of cases. So it's good presentation. We'll have an exciting discussion at the end after we finish our third talk by Dr. Daggubati. and we'll come back to you for the discussion. Just stay on. Thank you very much. Brilliant presentation. Now we have Dr. Ramesh Daggubati. Dr. Daggubati is Associate Chief of Cardiology and the Director of Structural Cardiology at West Virginia University. And he's well known in India. He keeps coming every now and then, and very popular also. And my good friend.
Dr. Bang, thank you very much for this opportunity, and I really admire the interest among our Indian audience to stay up late on Sunday evenings, which is usually reserved for their families, to listen to this. We really have a large number of people who are logging in. And actually my talk is about management of embolized materials. We mainly talk about retrieving the embolized materials, but if there is any material like such as a fractured wire or a small tip of a microcatheter, you can either crush it against the wall and push distally. But my talk today is about retrieving embolized materials. So a lost stent, which is still on a guide wire, and you can actually do a balloon retraction, meaning a small, less than 1.5 balloon can be tracked through the stent, inflated and retracted. So normally people say go beyond the stent, which I'll show you then in the next picture. But I like actually to be a little bit within the stent. So half of the balloon is within the stent and half of the balloon is beyond the stent. So that way I think it is easier to not really cause intussusception of the stent or actually foreshortening, and it can be brought back easily. So that's what I would do. And at one time, actually, I had a similar patient in radial, and it was, I think, a 3.538 Zions drug-eluting stent that was dislodged. I pulled it back, and rather than trying to take these through the sheath, sometimes you might actually cause more harm. Then they start getting a little bit shriveled up and foreshortening, and then a bunch of material. And so I actually just deployed it in the radial artery at 3.5, which is, I think, the right size for the radial artery, and then went ahead and did the procedure. So when you withdraw, it is usually, try to make sure that you don't deform the stent with the balloon distally. So snares is the talk of today. We are looking at several snares, and the gooseneck snares or loop snares with the end snare, and other ways of making a snare at your own home. If you don't have snares, and snares are expensive sometimes, you can just go through a diagnostic hub or a shaping material that you have, and usually I use a whisper wire to advance it and make the loop come back and bring it back into the hub back. And so as you see in picture C here, now you have a totally snare that is available. And this snare, now you can actually advance that through the guide, through the microcatheter, and advance it as use it as a snare. And so that said, there are other ways of lost stent which is still on a guide wire. You can advance the gooseneck snare or end snare or a homemade snare and try to pull it back with the stent and the wire by itself. And sometimes you can actually make a multi-level snare, petal snare, to capture the stent at the ostium. This is only useful for ostial places. And wire wrapping, I have tried this, but I have not really been very successful. I do a wrapping of this is a Cheapman's snare, I think, and you can wrap it with another wire. And all my experiences have been really not successful, and I had actually more broken material than what I started off with when I tried to do wire wrapping. So I don't do it personally right now, but if somebody is doing it and if they're successful, that is well and good. Balloon trapping is very simple. I think advance a microcatheter, a guide extension catheter over the wire, and as long as the stent is still on the wire, you can advance a small balloon and trap the balloon and the wire and pull it. Everything as actually in one piece. Along with the guide catheter, everything comes out from the sheath. So make sure you inflate the balloon slightly at a higher pressure, more than 12 atmospheres, and make sure that it is trapped well. And don't use small balloons for trapping. It is better to use a same 2.5 millimeter or a trio balloons. So, and you can see very rarely forceps or biotome can be used for people who have a stent dislodgement in the ioto-osteal junctions, and those can be usually taken with the biotome. So let me show you some few cases. This is a 64-year-old gentleman who was referred to me for PCI. They found that he had an inferior ischemia, and they did a diagnostic catheterization, and I was showed mid-RCA heavily calcified lesion. So this was my third rotablator case, and starting at 4 o'clock in the evening, and I just wanted to also get out of the cath lab. So this is a perfect scenario. When you're in a rush, you're going to delay the procedure. So never be in a rush, even if it is 4 o'clock or 5 o'clock or 9 o'clock at night. If you are thinking that you might have to rush somewhere, please postpone the patient. And lessons learned from our bad experiences. And so I said, okay, your third rotablator, that's okay, all right, let's get it. And I went in, and the rotor got stuck. Why rotor got stuck is because I chose a 1.5 burr, and I was rushing through it, and I might have pushed it through the lesion. So these are, as I said again, large burr to artery ratio. Then trying to advance the rotor forcefully, and doing longer runs are all actually increase the risk of stuck rotablator. So this was stuck. So what do we do normally? I advanced another wire. I think this was initially a BMW wire next to it, and I tried passing another balloon and trying to pull it back, dislodge it. It did not work. And some people said inject something else. I injected in, I think, some mineral oil or something. I injected through the guide catheter. It didn't loosen up. Okay. And then whatever the Boston tells you to go cut the back end and trying to pull it, nothing worked. So, this was a second experience for me like this. I had happened one time, and ultimately, number one, call the surgeon. The surgeon is waiting in the room. They're getting the operating room ready to take the patient. So you have at least some time while they come. So I told him that I'm going to, take it out forcefully. If it comes out, that's well and good. If it doesn't come out, then anyway, you're going to take him for surgery. And we agreed upon that. So I basically wrapped the entire back end of the rotor onto my wrist, and almost put my foot on the table and yanked it out. So forcefully yanking it out really worked. The rotor burr came back, but it actually, there was another wire after this. Another wire was placed. I think this is a Fielder XT wire, because the BMW did not do it, and I went with the Fielder XT. That one broke now. So the rotor burr came back, and the wire actually is now stuck there and fractured. What to do? So I went with another guide from the femoral axis. This was radial. So the femoral axis wire, and I easily snared that part of the broken fractured wire, and as you can see, it is not so difficult. And so once you capture it, it actually took it out. And and as it's that's a picture where it shows that it's coming out, and it's not easy, but it was still there and it came out. So I already had another wire through that. So never lose access. The broken wire is probably preventing it from collapsing on you. With that wire, from the radial guide catheter, I advanced another wire already, and kept the axis open all the time. So then once that is removed, we took a picture. Obviously, this is not something that unusual to expect abrupt vessel closure, and that's because we've been really messing up with the entire artery. So now actually we were able to go back and finish our intervention successfully without any problems. And so that is still TIMI 3 flow, and patient was discharged home the next day. So here is another patient, 74-year-old woman with on PE, on warfarin, otherwise well, out of hospital cardiac arrest, in cardiogenic shock, very severe shock with pH 7.05, lactate 4, and lateral ST elevations and hypokinesis on screening echo, and patient was taken to the Cath Lab for mechanical circulatory support with a balloon pump. and also to see what is going on, why is there ST elevations. And here you can see that there is some moderate RCA disease, but circumflex appears to be the culprit with the 95% occlusion in OM1 branch. So we decided to proceed with the primary PCI, the circumflex, with the BMW and overlapping 2.528 and a 2.523 science drug-eluting stents, and post-dilated the overlap part of that stents with the 3 or non-compliant balloon, and also the proximal stent was post-dilated. So then this picture showed that distal to that 2.528 stent, there was some narrowing, and you know, ideally we should have left it alone. Hindsight is always very good. And so we tried, okay, rewiring. So now this is the problem that we were having rewiring and the difficulty advancing 2 to 5 drug-eluting stents. And the stent was lodged, and we tried to pull it back because it was not going forward. And the next picture shows that actually the wire and the stent came back here. As you can see, it's almost in the ioto-osteal junction. So the guide is removed, and the stent was dislodged from the balloon. We reintubated the left main, and still unsure of stability of the dislodged stent. And as you can see, it's almost in part of it is in the aorta, and the flow in OM1 is now suffering a little bit. Thank God the patient had a balloon pump. So wired the LAD as well, and looked at it to see if there's any problems with the left main. There may be small dissection, not very clear, but you know, most of the left main looked okay, except at the distal left main at the ostium of the circumflex. So here, surgery is not an option because patient is an out of hospital cardiac arrest, and conservative probably is also an option. But since we are there, we said, okay, let's upsize to 7 French radial, then use the 6 French end snare through the 7 French GR4 to retrieve the crushed and dislodge the stent mass. And snares, as we said, that you know, you have to pick and choose what snare you want. End snares are much easier in the sense that there are 3 loops, and you may not get, may not lose trying to capture it. It may be easier than otherwise. So here we got a part of the stent here. As you can see, it is a little bit faint because it's a fluoro save, but the stented material was captured, and then actually it was pulled out, and I'll show you how it was pulled out completely. So then, you know, it's the OCT of circumflex confirmed no distal dissection through the large proximal dissection. Small left main distal dissection was there, and that was treated with the Zymes 3033 proximally and a 2.25 into 12 distally. And so that's the best flow that we could get. And I think initially we thought that this is enough for this patient, and let's see how she recovers from her out of hospital cardiac arrest. Even though we were able to retrieve it, unfortunately, the patient actually passed away from hypoxic brain injury, which did not improve at all. And the patient's family made her comfort care. So obviously therapeutic options, we will talk about surgical, conservative, and percutaneous. You always have to make sure your surgeon is called so that in case if you need a backup, as I showed you in my first patient as well. So let's quickly look at one more patient, and a 62-year-old male with the previous bypass surgery in 2003 had a PCI prior to this procedure, and 4 months afterwards he came with unstable angina, and cardiac cath showed a significant left main to osteocircumflex restenosis. And as you can see here, that's the restenosis. This is the protected left main PCI, and Lima to LAD is patent, and OM1 has some disease. So we thought, okay, just a single stent crossover protecting the OM1 branch would be enough, and that was the interventional strategy in this patient. So you can see the luge wire is in OM1, and the BMW wire is in circumflex, and the left main to LAD stent was performed. It looked very good, except OM1, we were not happy. So side branch Again, whenever you see some pinching of the side branch, but with TIMI 3 flow, now obviously you should leave it alone. And but here we try to balloon it and on OM1, and because of the ostial pinching. So, but when advancing the balloon, it appeared that the wire had gone through the struts and balloon could not be advanced and hence was removed. And when attempting to rewire again, we noticed that the wire was completely trapped and stuck and could not be removed either. So here the stent and is there, but the OM1 wire was trapped and the wire got stuck and it wouldn't come out, and somehow the tip of the wire wrapped into a part of the stent, and it actually made a hook like that, and it was now not coming back at all. So what to do now? So you could several manuals, including gentle pulling, advancing the balloon over the wire, or a microcatheter, were unsuccessful, to release it. And so finally, when we tried to yank it out or forcefully bring it, the stent has deformed and completely dislodged. So now that's a deformed stent, and as Dr. Jaffer has already gone through the longitudinal stent deformation, it can happen with any stent when you use a lot of force. So the guide might have gone in when we're trying to pull the wire back, and it caused stent deformation. So as there was no other option, forceful pulling was done that caused a fracture of the body of the wire with the distal end still attached to the stent. And so the fracture of the wire happened somewhere in the abdomen. So the wire is in the stent and through the guide catheter still. And so this is now kind of a big mess. So what should we do? So what we did was actually advance another wire and next to that other wire, and trapped the broken wire in the guide catheter and removed it completely as one unit. Again, guide catheter, the broken wire is a trapper balloon is right in the guide catheter, and the deformed stent came along with that. So and it was brought back, as you can see that in one unit into the femoral artery here. So it is all a bunch of a ball of stainless steel or cobalt chromium, and now it is very difficult to pull it out. At one time I had to do actually a cut down to get this one, call the surgeon. That's one option to do it. So that was in the beginning of my career. So I said, okay, that's in the femoral artery, we can come back to do it. So let's go back and first fix whatever we have to do, and of the left main. So we looked at it and see now actually it looks worse, and so we said let's do that first. And a repeat coronary intervention was performed, and this time we were a little bit smarter, so we didn't care about OM1, so let it go. The left main to circumflex is better to be handled. So I'm sorry about this picture. Somehow I don't know what happened. PowerPoint did not show me the circumflex and ostium and left main, but take my word for it, successful PCI of the left main and circumflex. And now we went from, once that is handled, patient is stable, we went from the contralateral femoral axis, and the dislodged stent was successfully snared and in the entirety out of the body. So use larger sheets here, 7 French or 8 French, and so that because the ball of stent material has to come through it, and I think it is much better to pull it out that way. So this is a retrieved stent, as you can see, metal ball. And so I just want to conclude saying that the stent deformation or dislodgement and wire fractures are rare, but potentially serious events. And the risk is higher in calcified or tortuous vessels and in bifurcation stenting. With the increasing complexity of PCI, all of us should take extreme caution to prevent such complication, and also should be familiar to how to bail ourselves out of these complications when they happen. Thank you very much.
Brilliant presentation. Excellent talk. We have seen several cases, all 9 cases that have been shown by all the 3 speakers. Superb. I would like the other 2 panelists also to come on video, please, so that we can have a discussion with the participants. And there are several questions being asked. Naturally, the topics are such that it will interest so many people. So question mainly is first starting with Amar. Amar, this PVL problem, paravalvular leak problem, post-surgery also is known to occur about 4% in the aortic valve, and mitral valve about less than that, about 3%. And so is known to occur after the catheter valve replacement in both the places. And but how do we decide whether the leak is central or it is paravalvular? Because the treatment will be totally different.
You mean in the aortic position?
In the aortic position.
Sure. Yeah, I think, when you have aortic regurgitation after TAVR, as you said, the key is to understand whether this is a valvular regurgitation or paravalvular. In truth, I think valvular regurgitation is quite rare. The only specific times you're going to see it is when you have a very large annulus and you've substantially post-dilated the valve or implanted the valve at a very high fill volume. There's always the potential risk that if you've implanted the valve and then recrossed with a wire or a catheter, could you have some valve perforation? But I think much more commonly, of course, this is a paravalvular regurgitation. And I think this is why it's important that all of us as operators are looking at the CAT scans and the pre-procedural imaging, because that's going to help you understand what is the type of paravalvular regurgitation you have. Meaning, is it an issue with sizing, and then the treatment can just be post-dilation of the valve? Is the issue that you have a somewhat calcified ventricular outflow tract? It's not too bad, there's a little calcium, the seal is bad, so you might still feel comfortable to post-dilate. Or the last issue is that you have a significant calcium burden in the annulus and the ventricular outflow, and post-dilation doesn't feel like a safe strategy. And so then you want to consider to do a paravalvular leak closure. And I think in that regard, it's really a question of what the operator feels comfortable with the imaging. If it's something you do often enough, you might feel comfortable just to use a surface echo. If you have a good echo tech to show you nicely where's the location of the paravalvular leak and plug it. Some people feel more comfortable to use ice. And some people, if in a case like this, might feel more comfortable just to start with general anesthesia and TEE with the idea they're going to do a paravalvular leak and they feel most comfortable with that imaging. I think either way, any of these ways is fine. But the key to me is understanding the pre-procedural aortic root morphology, because that's going to help you understand what is the safe mechanisms by which to treat it.
Absolutely correct. And what kind of plugs, vascular plugs, do you prefer when you seal the catheter treatment of the paravalvular leak in aortic position?
Sure. So in the aortic position, it depends a little bit. Oftentimes, in the surgical valve PVLs that I close, I'll use the AVP4 device because it's a relatively small, a short profile, and the device sits quite nicely right in the area of the leak. There are kind of two domes on either side. In the catheter valve, like a Sapien valve PVL, or even with this Edwards Intuity valve, which is the balloon delivered surgical valve, it's such a tall frame that I really like to still use the AVP2 device. I place one disc at the inferior aspect of the Sapien 3. The second disc goes at the top of the Sapien 3, and all in between is the cylinder that squeezes into the PVL space.
And there's a question that post MVR, if you have a infective endocarditis related valvular leak, is there any way you can treat by catheter?
I think, our surgical colleagues often like to, give us a call when they have a really bad surgical risk candidate and they hope we can do something percutaneously. In truth, it's not a good idea because we're just going to increase the infections, adding more material, increase the risk of annular abscess and so forth. In truth, it is something that I've done one time, and it was only because this was a very young patient who was in a hemodynamic extremis with an infected mitral valve annulus and PVL. And so the point of doing the percutaneous closure was really just to save her allow her to recover a bit. Her multi-organ failure did improve, shock liver, shock kidneys, etc. And then in that same admission, of course, she went on to have a much more definitive surgical treatment of the annular pathology and infection. So I think it is, to be honest, I think it's inadvisable unless you know that as an institution you've committed to the long-term care of this patient. That includes surgery.
Okay.
But that's just my 2 cents. I don't know if, I'm sure Farouc and Ramesh, you guys have dealt with similar scenarios in the past.
Any one of you would like to explain more? Sure. Any one of the panelists would like to come in and explain more?
Yeah, no.
Do you have any experience with this?
Yeah, so I also did one similar one with a young guy who, with infective endocarditis, while being undergoing surgery, he coded on the surgical room OR during induction of anesthesia, and they had to suddenly do whatever they could. And obviously had a huge paravalvular leak. And after being treated with antibiotics, and we brought him back and we did it. But there was already a patient processes kind of mismatch, and now he was still symptomatic even though the PVL is healed. So when he became more stable, we sent him back for surgery to redo the whole root enlargement and replacing the aortic valve. So I think for temporary, you can do percutaneous methods in people who are infected at that time, but I think on long term, that's not an advisable one at all.
Okay, good. Thank you very much. And now next question for Amar again, that how is the long-term stability of the leaflet after SLD?
You know, this is one of these situations that is, it's certainly, there's no robust clinical data to say what are the outcomes. Even in some of the papers that are published, and in fact, just last year, there was a nice paper of patients coming for repeat mitral clip after mitral clip failure in JACC intervention. You know, it's in that paper, only 8 patients had a repeat procedure because of an SLD. And of those 8 patients, only 2 were successfully treated with a repeat mitral clip. And so the data is not robust. I think that in the decision making, when you have a mitral clip failure, a single leaflet detachment, the way to think about it is, first and foremost, always, what is the surgical risk of the patient, and can they tolerate a repeat surgery? In the US, at least, the approval for mitral clip is truly just for the high and extreme risk kind of surgical patient. So at baseline, it's not a great situation to take the patient for operation. And so if that's true, if the patient really is not going to tolerate operation, then I think we can consider these various strategies like the one I showed you. Sometimes we have found that even with a single leaflet detachment, if it's a very small tear of the valve, you can place a clip just next to it and it shores up the valve enough that it works. But I don't think there's any robust data to say long-term how effective is this. I'll tell you anecdotally, these patients we've had to treat either with a leaflet detachment that we treated in the index procedure or that got transferred to us, they have done well. But this is a very small handful of patients treated over a number of years. So I wouldn't say there's any objective evidence I can provide for long term.
Okay, how about, there are 2 types of clips, mitral clips. One is NTR and the latest one is XTR. Do you think the XTR has a more advanced features so that it will give more stability and leaflet detachment will be less?
You know, I think so we use both the XTR and the NTR, and in fact, we're part of the smaller series of centers now that is using the next generation clip that allows independent grasping and also has a wide clip and a narrow clip in both the NT and XT versions. I think it's really just a question of, again, understanding in the procedural and pre-procedural imaging the integrity of the leaflet tissue. In patients with a big mitral flail, like a big P2 flail, the longer XT clip is very helpful because we can grasp more of the flail and really stabilize the leaflet. In patients with functional MR, truly, we're much more often still using the shorter, the NT clip, the original length, because especially with the functional leaflets, when they're really tethered out, I think if we grab too much leaflet, the leaflet that's left behind is still tethered, and so we're causing leak on either side of the clip. And I think we're putting a lot more tension force also on the leaflet themselves. So in truth, for the functional tethered leaflets, we're still using the NT more often.
When you have a functional MR or a degenerative MR, there is a specific kind of microclip treatment. And when you have a combination of two, like functional plus a degenerative MR, I'm told that the XTR seems to be working better there. Is that true?
Again, I think it's just more of a question of what is the primary pathology. In a case of a degenerative MR, as long as there's a large area of prolapse or flail, we will usually try to use the XTR clip. I think, you know, it stabilizes the leaflet very nicely. And so if it is someone that has a prior bypass, they have an EF of 40%, so you know there's some functional component, some annular dilation, but now they've lost a cord and they have a DMR, that case I'll still like to use an XT clip most of the time. But it's really the, you know, even in these functional patients, if you look closely enough, especially with the current beautiful echo imaging we have, you'll always see a little bit of degeneration, a little bit of a shaggy leaflet. I know we kind of define that as combined pathology, but in truth, if it's a primarily functional pathology, I still like the NT clip.
Yeah. How do you decide which scallop to clip, whether A2 or P2 or A3, P3, which scallop to be clipped based on the streaming of the MR?
Yeah,
So
I mean, you really want to look in the exact origin.
The idea is to prevent leaflet detachment if we decide a proper strategy.
Yeah, I mean, I think this is the way in which our imaging colleagues help us the most, is to acquire as accurate imaging as they can, so that we understand, is the leak in the middle of A2, P2, is it on the medial side, the lateral side, at a different scallop? It's the procedural imaging, I think, that's really imperative. And so our imaging colleagues, you know, the ones that are coming to the Cath Lab most often are not coming there just once a month or once every 2 months. They are coming every week, and we have a very specialized kind of Cath Lab imaging force, so that they understand the procedures as well as we do as operators.
Yeah, absolutely. And how do you find the results of clipping after the functional MR? Although COAP trial has said very favorable result.
Yeah.
But your personal experience?
We've had a very good personal experience. And again, I think it's a question, you know, as Ramesh said it best, these are all procedures that you can't go into with the expectation to be rushed. You know, you have to take the time. That means understanding the leaflet attachment. It means understanding the degree of mitral pathology. Do you need to put 1 clip, 2 clips, 3 clips? Because you want to leave the Cath Lab with as little MR as possible. We know if you compare MITRA FR, which was a negative study, and COAPT, there was a much higher incidence of residual MR in MITRA FR. So it wasn't a very high quality procedure, with no offense, of course, to the enrolling centers. And we know even in the TVT registry that residual MR is a very clear prognosticator for worse outcomes. And so in functional, it's much more challenging to leave the Cath Lab with trivial or 1+ MR than it is in the degenerative cases. So we have to be really, really careful. And that's also with patient selection. You need to make sure these aren't patients that have a significant right ventricular dilation and dysfunction. Their FMR is truly what's driving their clinical decline. And also you need to be a little cautious with the FMR patients when the entire coaptation line is leaking, because we can't close the entire coaptation and give them MS. So maybe this is a patient that needs a coronary sinus annuloplasty or a direct annuloplasty. Maybe MitraClip isn't the way to go. Maybe they need a catheter mitral valve replacement. So I think it's important for operators who do MitraClip but don't do other mitral valve percutaneous strategies to know what are the limitations, and should they be referring patients to a center that does these other things if necessary in some patients.
Absolutely. I think, is there any, when you have a functional plus the degenerative valve, do you still prefer a mitral clip, or do you change your strategy based on if they both are, you know, some cases they have both degenerative plus functional MR?
Yeah. No, that's a good question. Again, I think looking at the, again, what is the primary pathology is one aspect. In the United States, we only have MitraClip that's approved. You know, in patients with a very degenerative and functional valve, we might consider a transcatheter MV replacement as one of the trial devices. The other option is the Carillon, the coronary sinus annuloplasty device, which we use as part of trial. And the interesting thing about this is, while you can't necessarily enroll patients that have a clear degenerative component, if you're not sure that you'll get a good result just with a MitraClip, you can enroll them in Carillon. And then once the device is placed, 6 months down the road, if they still have significant MR and symptoms, you can then add a MitraClip. So this is sort of an interesting aspect of that trial.
Okay, there are several questions coming up and flooded with the questions, absolutely. And there are chats also. There are several things that are happening simultaneously. And it's interesting to know. Hemodynamically speaking, long-term result prognosis-wise, when you have a PVL after the aortic valve TAVR, how do you decide this is to be treated and this can be left alone, mild or minimal can be left alone? And how do you decide that?
You know, we're pretty thorough about understanding the degree and the clinical ramifications of PVL. We not only by the echocardiogram, but by aortography and also by measuring the ventricular diastolic pressure and also the aortic diastolic pressure in comparison to the beginning. We don't like to leave, frankly, any PVL. We know that to some degree, most PVLs are going to cause issues in the future. So we're quite aggressive, whether it's post-dilation or paravalvular leak closure, what have you. We try not to leave anyone with PVL. And in sort of in most recent years, our rate of 2+ PVL, at least in Cleveland Clinic, has been anywhere between 0.2 and 0.4%, so quite low.
30-day mortality is very high if you leave the PVL. You know,
yeah, no, short and long-term mortality is certainly
long-term mortality
so
as well, very high. So PVL is a very serious complication of TAVR or mitral valve replacement by the catheter. Am I right?
Absolutely.
Now, there are several questions. Stay on, Amar. There will be few questions for you. So, Dr. Farouc, you have a very interesting case of penetrating the covered stent in the left main and then stenting the circ, and you saved the life of that patient. How did it occur to you, and what wire exactly? Can you a little bit explain on that basis? It's a very interesting case.
Yeah, so in this world
I've never seen that before.
That's saying something. So thank you. The concept had been raised by kind of in the endovascular realm about fenestrations and going through stent grafts and placing these where they're custom designed. And there were some anecdotal reports that I had just come across, I believe literally on Twitter about 3 or 4 years ago, about people discussing this. In that emergency situation, it's always hard to think about all these things. So that's why it's important to prepare and have a mindset for an algorithm that you might go through in these situations. Our initial intent was to not cover the circumflex ostium. And actually, there was still some flow until we post-dilated, and that's what really kind of just sealed it off. If I had known that, a couple things I think about is whether or not I would have left the jailed wire in there. I'm not exactly sure I would have done that. In this particular case, what was really, really essential was the fact that we had already done circumflex stenting. So we had a visible target to angle for with a stiff wire. If there had not been this, so this is an advantage of doing a DK approach up front for the left main, because we've stented the side branch. I knew exactly where to puncture. If I did not have that, that's a very, very hard situation. Then you really are going blind, and you're not going to really know quite as easily. So at that point, I realized that even though it wasn't a huge circumflex initially pre-intervention, it was moderate. It turned out to be bigger after we recanalized it, but it was enough to cause the clinical symptoms. So we had to try to do something or ride him through it. Mechanical support with a 14 French and his physiology, his size would have been particularly high risk as well. I think we would have supported him through the circumflex infarct. He would have had a pretty reasonable sized infarct. But this was worth a shot. And given the visualization and given the tools that we had, the familiarity with stiff wires and angled microcatheters, it allowed us to choose that.
Forcing the stiff wire across the covered stent, I fear that you may get a coronary perforation in the suck.
So at least if you looked at that initial fluoroscopy store, Cine store, there really was exits of wires going through into, perhaps the ramus territory or extravascular for sure. And in general, as long as you do not follow the wire perforation with a microcatheter, those are likely to seal. We had already, planned to, place a drain for him, and we probably would have handled that part okay and partially reverse and so forth. So I wasn't so worried about that. It's just if you follow with the microcatheter, then you can really open up a large hole. But the stabbing part, I think was reasonably controlled. And again, we had a good target there.
Brilliant case. That was a very, very brilliant save of the patient, a very thoughtful procedure. I never heard of this before any time. And now coming back to the perforations, you have shown several cases of perforation in various ways. And one thing which I would like you to cover, that when you have when you are doing a retrograde PCI in situ, wire perforation can cause havoc in the either of the collateral, either septal collateral or the epicardial collateral. How do you approach them and how do you treat them? I understand septal collateral may be inconsequential, but definitely epicardial collateral, they are often used nowadays. 30–40% cases are with the epicardial collaterals. That's what.
So starting with the epicardial collaterals, these are clearly the highest risk collateral for perforation. Again, because we'll talk about the septals, but really, really important to have skills in handling perforations. The most important thing about a collateral perforation is recognizing that bleeding can occur from both sides, antegrade and retrograde to the perforation, which means one, in order to seal this, really has to actually plug from both directions, north and south of that tear. So often the wiring the epicardial collateral is often usually done fairly safely. The major cause of the collateral perforation is when the microcatheter is being delivered through this very tortuous zone. They're often not aware that there has been a perforation until they actually start to withdraw their externalized wires and microcatheter covering. So if there is a perforation that you notice while you're doing the wiring and delivering the microcatheter, if it seals, the person's stable, it may be to your advantage to finish treating the total occlusion and then be prepared to come antegrade. So then what you do is you basically have your externalized wire, which you will bring back. You will maintain access on the antegrade side. So you'll actually bring in a second microcatheter antegrade, and you'll have microcatheter and microcatheter placement on both sides of the tear. Then what you're going to do is you're going to pull the wire that was externalized, you're going to pull it all the way out and deliver coils in both directions. That's the most typical way to kind of deal with it. Can do plugs, can do coils, you can do thrombin and gel foam. Thrombin we worry about because of its ability to flow into native coronaries and aortas and things like that. But you're going to come from both directions, most importantly. And you got to stay anticoagulated during this time.
Correct. And in LST, longitudinal stent deformation, you did a rota and took care of the stent which was deformed, and then did a normal PCI and stenting of the area. Am I right? Can you use laser?
Yes, we restented.
Yeah. Can you use laser?
We have not tried. Fortunately, I don't have a tremendous amount of experience with this particular complication. We have not thought about using laser in that situation, simply because, drawing from our experience with severe calcification, laser is not particularly effective in those situations. So for metal, I don't think it would really be an optimal solution. So we would probably not to choose laser. We would typically restent, use an NC balloon to smooth out any jagged edges, would image for sizing, and then restent across.
I had seen one case live in which laser was used in instant restenosis in LED diagonal bifurcation. And case was done by Dr. The famous doctor from the Italy. He was very well known. And Colombo, Antonio Colombo. And he has done laser in both the stent and the side branch and the main branch stent, and then redeployed another new stents, although 3 and second layers, maybe more layers of stent, but it was very successful. Patient was high risk for surgery. ST score was 7.8 or something like that, if I remember right. It was shown in TCT live. So that was a great case. I always remember the laser being used in the stent deformation.
It was a deformed instant restenosis for sure, but there was also a deformed stent.
A deformed stent, yes. It was also at the ostium, the deformed stent. That's the cause for restenosis within 3 months. The patient
yes, I think if you can pass any gear, ultimately, then to re-expand the stent is really the target. In this case, we couldn't even pass a microcatheter all the way down, so chances of passing a laser through it were not going to happen. But absolutely for kind of certainly for multi-layer restenosis, laser is essential and critical for obtaining expansion.
What is your treatment for ISR lately? What is your preferred treatment for ISR, repeated ISR in a vessel?
Yeah, we have embraced brachytherapy quite a bit. So it's our partner hospital at the Brigham has had this program, and we're actually resuming ours because we are finding that we have 3 to 4 patients per month that have had multi-layered restenosis. And the most important thing I would say about that is that the first stent that gets placed is often underexpanded. It was undersized, underexpanded, and that's because imaging was not used. And so this is really, if you're going to put a stent in, doing it right the first time is the most important thing. After that, then it really becomes an aspect of trying to use laser to expand these stents, and that may require more intense procedures. We look forward to the shockwave experience and seeing how this might work for some of these very complicated ones. And then pharmacologically, we've been looking at silazostol and colchicine as anti-ISR therapies.
Yeah, that's really good. But the Achilles heel of left main angioplasty, which is now currently very in vogue and very popular, is the LCX restenosis ISR of the LCX ostium. And lately there is a data on stent versus the drug-eluting balloon, DEB. And it seems DEB is working in the ostial restenosis. It gives superior result than this stent again. That there is a study presented, RCT, proper RCT presented of 300 cases. And I don't remember which journal and who was the author, but in that it was clearly shown that DEB is superior when you have ISR in the circumflex ostium, particularly if the circumflex ostium size is more than 3 or more millimeter. So it was very interesting.
We look forward to it.
Because
it's really great. And
we always try to avoid more layers of metal. That is the principle, that avoid more layers of metal in the coronary, that gives long-term result, better long-term results. So this was one point.
I think it's great. We get to learn from you. We really are obviously super eager to have coronary DCBs in the United States. Yeah. Still probably several years away. It'll probably be delayed a little bit on the paclitaxel side with the recent controversy. Yeah. But there are sirolimus balloons that are out in Europe. And do you guys also have access to a sirolimus balloon, the Magic Touch?
Yeah, we have. For a long time now. We are using Magic balloon here, sirolimus coated balloon. We are using, and we are very happy with the technology. It's really good. It's working very well. And they have very different size, and all the sizes are available. It's a local company for us, Indian company, which produces the magic balloon, drugulating balloon. And another thing that particularly related to the ISR, apart from the ISR in the circumflex particularly, because that's the one which is now troubling everybody, because left venoplasty and you have ISR coming back at the ostium, and you don't want to have a more layer of stent again and create many problems for the patient for long-term results. So in that situation,
totally agree. I love that concept. There's something about the geometry of the ostial circumflex when you stiffen it with a metal stent. I think the flow, there's a major flow disturbance at the true ostium. So anything we can do to avoid rigidity and straightening is really great. So I love the concept of a balloon over a stent in that situation.
Just stay on. Next question is for Ramesh. Ramesh, how often do you make homemade snares, and where do you use homemade snare? Various types of snares are available, and snare with multiple loops.
Only in India and China.
Snare, and then you have a micro snare, and then you have homemade snares. So which snare to use and when?
So yeah, most of the time we use commercially made end snares or gooseneck snares, and unfortunately, when it happens in other countries where within Vietnam, China, sometimes I've had experience that they don't have, even in India. I have to make sure that all the equipment is available, but it is really too much to ask for each and every center to have all the equipment. So, and that's why we need to know how to make our own homemade snares when the situation arises that in the small centers, probably not Mumbai, but in other small centers where I've been and practicing and proctoring, you might have to get into a situation where you need that. So it has happened to me in Vietnam. And once I had to balloon tamponade a perforation for almost an hour in China while waiting to get a covered stent, and because it was not available. So I think in the United States, we're lucky we don't have to do that, but I'm sure there is always an issue with other places.
What is your experience with new covered stent that is Papyrus? Do you have?
I actually don't have any experience with Papyrus. We only have used Graftmasters, and I was actually going to ask Farouc. I think someone.
Let Farouc come in and explain.
Right. One of the question was actually. I have actually a question for you, and then you can answer the question. I think from Dr. Hazra, I think, or Dr. Chauhan asked that question. Have you used a cautery on a regular softer wire to perforate or fenestrate the covered stent? And could you do that? So the stiffer wire, your 20-gram wire, can it go through 2 layers when on Graftmaster?
Like, let me come in. The Basilica, they use the cautery in Basilica. Am I right, Amar?
Yeah. We do, for the Basilica, we use the electric cautery for the Basilica, the aortic valve, for the lamp.
On the wire. It's a cautery on the wire. Am I right?
Yeah, exactly. So, and usually we use the same Estado 20-gram wire that Farouc showed in his case for the circumflex. Yeah. And so we just, we shave the wire a little bit at the end, apply the bovine needle to that, usually at 70 a cut electricity. You have to make sure for Basilica Lampoon that you have shielded the wire properly to allow the electricity to go to the end. So we use a piggyback catheter to shield the wire in order to provide that electrical force at the end.
Absolutely. Farouc? Any experience with this cautery?
We've had 2 cases of coronary E-cart that we've used in total occlusions for flush occluded right coronary arteries coming retrograde and not able to externalize in the aorta through conventional techniques where the wires just keep going up the aorta and the sinus. And so we have used E-cart for that. So we have a little bit of experience very similar to as Amar was just detailing. As far as going through a Graftmaster with 2 layers, we don't know. I don't actually know specifically if that's possible. I would think with PTFE, any stiff wire should be able to get through that zone. Obviously, puncturing through 2 layers is going to be harder than puncturing through 1. The time it takes to write the IDE protocol to get approved for the humanitarian IDE for the Biotronic Orsero is well worth it. The ability to have a covered stent go through 6 French, it's very, very deliverable compared to the Graftmaster. I don't think we'll ever use a Graftmaster again unless we had a shortage of something else, but we're just going to keep stock the thinner strut ones. They really do deliver well.
Absolutely. Ramesh, any more questions? Amar, any points that, and Farouc, anyone of you would like to add some points in the discussion? And the questions are several and chats are there. I think most of the questions are covered, but if some question is not covered, Ramesh, do you think there are questions left uncovered?
Yeah, I think what we answered is, I think Dr. Chauhan had asked about whether we could actually do the upsize the femoral. For me, I think actually he asked us whether we could upsize the femoral sheath on the same side when the dislodged and deformed the stent. Yes, of course. I just felt that I didn't want to leave the left main alone first, so I went on contralateral, fixed the left main, and then went back from the left side to snare the stent, which is on the right side. So I think it all depends upon whether the patient is stable or not. And I think a lot of other experts are also have commented on other questions on the panelists. They've really asked a great number of questions. And I actually have a question for either one of you, and please let me know. I have a patient with an aneurysm, which almost an LAD aneurysm, which extends to a side branch. So how would you treat that with the Graftmaster? Would you put a side branch? The question was asked, I think, by Dr. Hazra, was that in your patient, would you have left us leaving a wire in the side branch would have helped you when you put a covered stent, or it would hurt you? Farouc?
Yes, I was thinking about this question. I think in this prior case that I just showed, because I knew exactly where the circumflex stent was, that was easy to aim for a target. If I did not know where the target was, leaving a jailed wire in is an option. And I think I would probably choose something that had a hydrophilic front, so that's slippery to pull back. Trapping it, with metal and plastic makes me a little concerned. Yeah. My number one concern is that usually for covered stents, we're post-dilating at very high pressures, and so we really might have a chance to trap that wire. But if it were a large side branch and I really feared for the complication of losing it, then I would protect it and try to rewire and puncture using that as a rail guide. Yeah,
my recommendation is I wouldn't, because you're then decay crush, and now you're putting another PTFE. So, I mean, unless you're prepared that you're going to actually have a trapped wire, and you have to start thinking 2 or 3 steps ahead. So I wouldn't usually do it. And so in my patient with an aneurysm, if I have to treat it with the PTFE and has a diagonal that is coming off, how would you fix that? LAD aneurysm with the diagonal side branch?
Yeah, that's a super hard question. I've only seen some anecdotal, haven't done this. In an ideal situation, you'd be able to fenestrate exactly where you wanted to ahead of time on the bench. That requires, expanding the stent, puncturing it, recrimping it back down and blowing. It's really kind of pushing the envelope. There is an SKS possibility if you were really desperate as well, where you put in, 2 stents, one in the side branch, one in the main branch, and you'll have 2 barrels coming in, but at least you'll have some blood flow in the diagonal. The only downside of that is certainly, plastic on plastic, 2 layers, double barrel. Could lead to a higher stent thrombosis risk. Probably depends on the side of that. But if you did that, then if you were still nervous, you could still come in through your main branch stent, puncture again, which is actually something I'm thinking about, haven't tried, but puncture again for where that initial SKS stent is, and then come back and tap stent that, and then crush everything further, so that you would have a tap at the side branch. It's probably something that could be done. And maybe in that situation, the right way to do that is not to do SKS with two covered stents, but SKS with a DES in the diagonal and a covered stent in the main branch.
Yeah.
I'm happy to chat about that further. Yeah.
Yeah. SKS with covered stents.
I think that in this situation, I'd probably choose SKS covered stent in the main branch. The side branch may not need a covered stent in this situation because if you have to repuncture through the covered stent to get into that side branch, you'll have a metal target. No reason to put a plastic metal target, just a regular metal target. Then once you re-fenestrate, you'll end up with a tap type stent result, and then you can just crush that original DES quite easily in the side branch, just with post-dilating with a pot, and I think you'll probably be okay. Okay,
Ramesh, I have one question for you.
Yeah.
If you have a broken wire in the distal vessel, distal part of the vessel, what will you do?
So if it is a small segment, it's a very short segment, you can just leave it alone and don't worry about it. Sometimes I have had a microcatheter tips that have been broken. I pushed it into the septal branch, and I think they're fine. Even if the thrombos off, that is small branch, small part of the wire, it's okay. But if it is in a larger segment, try to crush it with another stent, and obviously that it is fixed in that position and it doesn't go any further down. And so you're stabilizing that, and but you're committing to at least in our patients, a couple of patients we have committed for long-term DAPT.
Oh.
So either push it to the smallest part. If it is a small branch, leave it alone. If it is a long segment, fix it, anchor it with a stent, even if the vessel is normal, so that it doesn't cause any further embolization. And then you're committed for long-term DAPT.
Okay, Farouc, I have one more question for you. It's about the, if you have a perforation in any vessel, where do you, put the balloon, inflate the balloon proximal to the perforation or at the perforation?
I usually try to overlie the balloon over the perforation itself.
Over the perforation.
Yes.
Low pressure
absolutely.
or high pressure? Low pressure.
I try to be lower. So I do try to be lower pressure. I was going to make a mention.
So that slow flow can be there, and there can be a thrombus formation. Is that so?
Well, partially that, but partially I've had one terrible situation where using an aggressive dilatation to seal actually further tore the perforation after a rotational atherectomy case, and it basically shredded the entire vessel, and that required urgent surgery. And so I think being a one-to-one and just occluding flow is usually enough. I don't want to be particularly high pressure in those situations until I can get a covered stent across it and really make sure I'm in stable parts of the proximal and distal reference where the artery is not going to tear.
And how do you decide reversal of heparin in all cases or selected cases?
I rarely reverse under 225 to 200. That's where I'll get to because I know I need to do some coronary work. Once we're done with the case, it really depends on if there's any leak or not. If there's no leak, I'm just going to let it fade because we often have stents that are in place and I don't want to risk a stent thrombosis. If there's still an ongoing leak and I didn't put in metal, then I'm absolutely going to fully reverse. I usually put a pericardial drain in before I hit the reverse, full reversal in case there's blood that can clot every now and then in the pericardium. And that's a very complicated situation. So we usually drain first, then do full reversal.
Yeah, I actually always do balloon tamponade proximal to the perforation because of the same risk which I had as well. And so never do it at the site of perforation because you can enlarge the perforation, especially in atherectomy type of patients. But even in otherwise, there is a you never know how much damage has been done with balloons as well, all stents. So always proximal, wait for the covered stent, either two guide systems or one guide system is up to your comfort. But early on, I think it's better to get another access guide and another wire, access put the wire up to the balloon, deflate the balloon, advance your wire, and then inflate the balloon back up. And then when you're ready to go with the stent, then again, immediately deflate and put the covered stent. At that time, you have to make sure that part of the covered stent is proximal to the perforation. If it is not proximal enough, you might have put the covered stent in the perforation at the site, but it will start leaking from proximal. Now you're committing to one more covered stent, which is overlapping covered stent is equally bad for thrombosis. So longer covered stent, making sure it is proximal to the perforation. The normal segment has to be there proximally as well as distally.
In my practice also, I inflate it before the perforation. If the perforation is in the proximal vessel. If the perforation is in the distal vessel, then I do at the site of the perforation with a lower diameter balloon, not 1:1, a lower diameter balloon with a lower pressure inflation. That allows the clot to form, slow flow, and allows the clot to form. That's what I think. I don't know, but it worked. Twice when I had a perforation distally, it worked very well.
I think your comments are well taken. I think that the reason to potentially seal across is it depends on the initial lesion and whether or not there was retrograde collateral flow. If you have collaterals into that zone, and often these are the types of vessels where, that's where I've been focusing on, then you're going to need to be able to seal from both sides. But in that case, yes, low pressure and not oversized.
Not oversized, because that will increase the size of perforation. That's the fear in the mind. And how long do you give the time? 15 minutes of balloon inflation or shorter time?
Longer. Minimum 15 minutes. Minimum 15.
Minimum. Same here. I also use 15 minutes and longer time if the perforation is there. So I think we had a brilliant discussion. Amar, Farouc, and Ramesh, anything that you would like to add and explain a little more you think we have not covered, so that we can enlighten the audience? Even now we have more than 200 audience.
Right. Someone asked about angiovac. I think, I didn't show it because it was not actually a stent or PCI. I had a patient with the right atrial mass where we actually had to stabilize the mass with a snare and then use the angiovac to suck the mass out. Most probably it was a thrombus or even sometimes myxomas can be done that way.
Brilliant.
So it's very exciting, Dr. Bang. Thank you very much for having me.
Very exciting discussion and very exciting presentations. I think brilliant CME that we had. And great attendance in all three formats of on the Zoom, more than 200, and the 700 on the YouTube, and about 150 on the Facebook. So we have great audience. I'm very grateful, very thankful to all the faculty. They have taken out the Sunday evening time and spared here almost more than 2 hours, which is a family time basically. Yeah. And I'm grateful to the participants for coming in large number and from the various countries, not from America and India, also from Bangladesh and other countries are also there. So it's very interesting. Thank you very much for your help and coming forward to deliver this talk. If we have more, more CMEs, I will get back to you. And I hope you are interested in coming back again.
Yeah, this will be fun.
Thank you so much.
Organized. Thank you, Dr. Bang. Thanks for involving.
You can do it from the comfort of your house. So this
was fun. This was nice.
And this is the only positive outcome of this pandemic, that we have started this online education platform. It's really interesting.
This is great. Nicely organized. Thank you.
Nice talking to you. So let me clap for all the faculty and the participants for an excellent session. Thank you very much.
Thank you.
Thank you, everybody. All right. Take care. Thanks.
Have a wonderful day.